We want to make sure that we discuss the details of the treatment and what treatments there are to be made, whether it's an oral drug, whether it's a subcutaneous injection or an intravenous injection, their potential for responding, and whether this treatment is curative or supportive, and what the number of visits are. So all of those different pieces of information that go into the decision-making process, I think are really important.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Hello, and welcome to the ONS podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS, and today we're talking with Sara Tinsley-Vance, nurse practitioner and quality of life researcher at Moffitt Cancer Center in Tampa, Florida, about myelodysplastic syndrome treatment considerations for oncology nurses. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Thanks for joining us again, Sara.
Oh, thank you for inviting me to this podcast, Lenise. I'm really excited to talk about MDS.
So let's jump right in. What are some of the goals for treatment, and how can they differ between people with high and low risk myelodysplastic syndrome, otherwise known as MDS?
Well, in general, for low risk MDS, I like to discuss goals of treatment with the patient and their family so that we're all on the same page and go over, like, what does it mean to have low risk MDS? A lot of times our patients have kind of looked it up or talked to Dr. Google before they come to our clinic. It has become a little more confusing lately because we have the International Consensus Classification, we have the International Prognostic Scoring System molecular profile, and we have the IPSS, and we have the IPSS-R. We can kind of plug all of those in with the patient, and then some of them really fall into low-risk disease. If they are truly low-risk MDS, the goals that I try to consolidate with the patient to make sure this is consistent with what they think their goals are to improve their counts, especially the anemia or cytopenias. If they're getting blood transfusions, we really want to reduce the number of transfusions that they receive because we know that that's linked to reduced overall survival, and it really impacts quality of life because they're coming in, they're getting typed and crossed, they're there for 2 hours per unit of blood, just getting caught up in that medical system, getting transfused. And we really want to improve their quality of life and prevent other complications from low blood counts. And then for your high-risk MDS patients, it's really a more serious discussion because we know that they are the ones that can progress to AML, and we're trying to delay progression to AML. So that means we're really trying to improve their survival, and we're also trying to manage their cytopenias, decrease their infection risk. So it's much more of a serious discussion with the higher risk disease compared to low risk disease, but it's their life and they have all the symptoms. So they're both good discussions to have with your patients.
Exactly. It's just like a slightly different, you're talking about goals of, what is your quality of life and your goals for treatment, but you're also, for the lower risk, you're focusing more on quality of life, whereas the higher risk, it's more of we want to keep you from getting to this point. What is isocitrate dehydrogenase variant or IDH variant MDS, and how is it treated differently than other types of MDS?
Yes, that's a mouthful. Definitely a difficult word to say. So we call it IDH variant MDS. And with that, the patient has the presence of an IDH1 or an IDH2 variant. These are acquired gene variants that can lead to the production of this oncometabolite called 2-hydroxyglutarate. Couldn't say that fast 2 times in a row. This oncometabolite interferes with normal myeloid differentiation. So what that means is the ability for your myeloid stem cells to grow up and become normal functioning cells. And then that can promote leukemogenesis, or the development of leukemia. This occurs in about 8 to 12% of AML cases and MDS cases. This is important that we have discovered that patients with MDS can have this IDH1 or IDH2 variant because we have medications that you can use that helps the differentiation process. You may be familiar with that with acute promyelocytic leukemia, where we have agents that can cause this differentiation syndrome. And so with this IDH variants and the drugs that we use for them in MDS, it's similar in that case, which is pretty unique.
Okay, that's really cool. I remember when we started doing that with APML and how cool that was, and think that we could potentially be doing that with AML.
It's a different thought process with MDS because we haven't been able to do that previously.
Thinking back to patient goals, how can healthcare professionals help tailor MDS treatments to align with patient goals?
This is so down my line of research. I study quality of life so that I can help patients learn what the experience is like, so that when we talk to them about survival and quality of life, we actually have the quality of life data so that they can make a fair and balanced comparison between treatments. So this question speaks to me. And the way that we can tailor the treatments to align with their goals is really getting to know the patient and their families and developing rapport with them, know what their symptoms are, what their experience, when they got diagnosed with MDS, how did they know that they had MDS? Were they having debilitating fatigue that interfered with their ability to do their normal activities? And then when we treat their MDS, are they expecting that that is going to go away or that that's going to get better? So for all patients, I try to review their complete blood cell count, a differential with them. That's one of the ways I can get to know what they understand about their disease, what those blood counts mean, and assess whether they've had a transfusion or not so that I can prepare them for when they get a blood transfusion or a platelet transfusion, and also going over their recent infections to see where they are in that process. Then you can tailor your treatments to align with their goals by building this rapport and seeing what their expectations are, and then seeing if the available treatments that we have, if that's even something that we'll be able to do, and just trying to help them self-reflect about where they were and where they are as we go through those treatments. And then we want to make sure that we discuss the details of the treatment and what treatments there are to be made, whether it's an oral drug and how we can help them incorporate that into their routine, whether it's a subcutaneous injection or an intravenous injection, their potential for responding. And really the important piece that we forget sometimes is whether this treatment is curative or supportive and what the number of visits are. So all of those different pieces of information that go into the decision-making process, I think are really important so that we can really tailor our treatment to what their expectations are and what's realistic for them to achieve.
It's kind of a unique world because in many other diseases, we don't have the maybe luxury of doing something like that. But I think that it also, we should be doing that with all of our patients as well so that they're part of the team.
Yeah, I totally agree.
Talking about the team, can you provide an overview of the care team involved in treating MDS and explain why it is often managed in the outpatient setting?
I work outpatient. I used to think of myself as an inpatient nurse practitioner when I worked in transplant, but most of the care that's delivered for patients with MDS is in the outpatient area. So we have a multidisciplinary team. Normally, the patient will come in and see the physician, maybe a nurse practitioner or a physician assistant or a fellow. And that physician makes a treatment recommendation or orders a bone marrow and then orders them to come back and see one of us to discuss the treatments. So he has a nurse working with him. So the nurse that supports that physician is involved. And then the nurse practitioner or the physician's assistant, most of the subsequent visits are scheduled with us. And then we have a nurse working with us. And we really are the ones that see the patient, at least at our institution, on a very regular and consistent basis. It's our whole team, we obtain the consent for transfusions of blood products, blood and platelets, which is once a year. We have that ongoing education regarding side effects of treatment, what to anticipate, what numbers to call during after hours or during the regular day. How do they get in touch with us? We manage the complications of their treatment, order those preventive antibiotics when they're severely neutropenic. And then our infusion center nurses, who we don't really get to see that often, are really a critical part of our team when they're getting intravenous or subcutaneous treatments. So most of this care is in the outpatient area, unless they're admitted with a complication of therapy, such as a neutropenic fever, if they're severely neutropenic, or if they have some kind of transfusion-related reaction. Most of the care is outpatient.
Which could be similar to some of the leukemias, but I think this is one that I've always thought of more often as being people being able to continue with their lives as long as we're able to manage their side effects.
And even something as simple as looking at their schedule and trying to coordinate their schedule so that they're not here at 8:00 in the morning for a visit with you and have to come back at 5 p.m. for a blood transfusion. That can make a big difference for patients. So things that we sometimes think aren't a big deal can become a big deal. So our schedulers are really important in that care team.
So let's talk a little bit about the treatments. What are some of the more common treatment modalities for low and high risk MDS?
So if we look at the approvals for low risk disease and high risk disease, those were really made based on the IPSS-R and sometimes the IPSS. Under those classification systems, when we think of lower risk MDS, we think patients who are primarily anemic but don't have increased blasts in their bone marrow. So if they have symptomatic anemia, we're using erythropoiesis stimulating agents. We want to make sure that we check a serum erythropoietin level and that it's not greater than 500, because if it's greater than 500, it's not usually going to be very effective. If we have primarily thrombocytopenia, then we can use, even though it's not FDA approved for that, a thrombopoietin receptor agonist like eltrombopag. If it's mainly thrombocytopenia, that's their main cytopenia. We can use antibiotics if it's mainly that they're severely neutropenic. Sometimes we use growth factors. Well, I guess ESAs are growth factors, but using filgrastim is one of the options if they're mainly neutropenic. For hypocellular MDS, we can use immunosuppressive therapy like we use for aplastic anemia patients. And some of the newer treatments that we're using is luspatercept for MDS with ring sideroblast and transfusion dependence. For 5q minus MDS, we are using lenalidomide if they don't also have high-risk genetics or TP53 variants. For our higher risk MDS, you want to have that discussion with those patients since they have really their life expectancy is much shorter than a lower risk MDS patients. You want to see if hematopoietic stem cell transplant would be something that they would be interested in if they don't have a lot of comorbidities and are relatively healthy. And if that's something they would be interested in, you could refer them to the transplant services to have that discussion. If they're not really interested in that, normally the standard treatments are hypomethylating agents such as azacitidine or decitabine. And if they have an IDH1 or an IDH2 mutation, those are also used in certain circumstances.
There's a lot of them. And there's a lot of things to look at, right?
Lots of things to consider. Their blood counts, their comorbidities, whether they're frail or not, and what their goals are. There's some patients, there's no way they would want to go through transplant. And some patients, they want to be cured. So it just depends on your patient.
We talked a little bit about the IDH1 and 2 variants and the newer therapies for those. What are some of the other newer and emerging therapies for MDS?
Well, we have a few in the pipeline. We have an Element MDS phase 3 trial, and that's comparing luspatercept with epoetin alpha, and that's in the treatment naive patients who are transfusion independent and have low risk MDS. And they're looking at the time to transfusion dependence as the primary endpoint. We also have a phase 1/2 Cambola trial, and that's testing luspatercept plus an ESA in patients with non-deletion 5q, ring sideroblast negative, low risk MDS, another mouthful. And then we do have other investigational strategies that are targeting that inflammatory signaling pathway in low risk MDS, and that's IRAK1 and IRAK4 inhibition. We have kinumab, that's one of the studies we have at Moffitt, and the NLRP3 inflammasome inhibition with DFB 890. So some of these are showing preliminary efficacy in decreasing anemia by mitigating the inflammation that's associated with anemia in some of those cases. For high risk MDS, we have hypomethylating agents in combination with venetoclax, that being very familiar to us since we treat AML also, and then CPX 351. That's also an agent that we use for AML, but not so much for MDS. And then we have olutasidenib, which is highly selective for mutant IDH1 inhibition, and then olutasidenib as monotherapy or in combination with azacitidine for newly diagnosed or relapsed refractory IDH patients who have IDH1 high risk MDS. And then also enasidenib for IDH2 inhibition, and enasidenib is in the NCCN guidelines for patients relapsed or refractory IDH2 mutated MDS, but it is not yet FDA approved.
Can you talk a little bit more about the immune modulating agents and how they can help treat MDS?
This is one of those things that you don't think of right off the bat, is treating MDS patients with drugs that we typically would use for patients who have aplastic anemia, and that would be ATG and cyclosporin. And that is typically used for hypocellular MDS. And most MDS patients will have a hypercellular marrow. So it's not the majority of MDS patients. So younger patients with hypocellular MDS may respond to ATG and cyclosporin. So we do use that in a small percentage of our MDS patients. And then also, you may be very familiar with lenalidomide for treating patients with other diseases such as multiple myeloma, but it actually is a very effective treatment for patients who have deletion of 5q type of MDS without other cytogenetic abnormalities. And these drugs enhance the immune function. They also reduce that inflammation and then can improve those blood counts. And it's pretty remarkable. I was involved with some of the initial studies that led to the FDA approval of lenalidomide in 5q- MDS patients. And some of those women that I can think of, because it's mainly affects women, 5q- MDS, although some men, they would go from a hemoglobin of 8 to a hemoglobin of 14. So when they respond, it's really quite remarkable. And we do have novel checkpoint inhibitors that are emerging as a potential treatment for higher risk MDS.
That's quite the bump in a hemoglobin from one medication. That's really cool.
It's really exciting. I think we get as excited as the patient when they go from an 8 to a 14. This drug is really working for you. And they feel better too.
I can breathe.
Yes.
I can walk.
Exactly.
Talking about anemia, about 85% of patients with MDS experience anemia, and some of the treatments that we use can actually make it worse. Can you talk about a few treatment options to help with the anemia itself?
Right off the bat, usually our first plan of attack, if their serum erythropoietin level is not greater than 500, is epoetin alpha. But these days, we can also think of luspatercept as a erythroid maturation agent. I think of those as predominantly for the anemia, and that they don't lower the other blood counts. That's pretty nice. And imetelstat or imetelstat, as some people pronounce it, it's also being used, but not in the first line setting. And with that agent, you do have to monitor for cytopenias. That's one of the dose limiting toxicities that we see, but there's an algorithm for working through reducing the dose if you get pretty profound cytopenias or can get pretty profound cytopenias. And we also can see improvement in anemia with our hypomethylating agents. But with those, we know that they lower the neutrophil count, can lower the platelet count and the hemoglobin initially. And it normally takes about 4 to 6 cycles before you see a response. But these agents, the ones that I think of primarily for anemia, ipoetin alpha and luspatercept, and then imetelstat coming close behind those two.
It's a pretty good group of things to work with.
We have options. That's great.
So you talked a little bit earlier about offering a hematopoietic allogeneic transplant for a patient with MDS. What might be the right individual for that treatment?
I think of this as a treatment for more of the higher risk MDS patients. With the IPSS-M, a patient can have pretty good blood counts and not increased blasts in the bone marrow. You could send them for a transplant referral up front without having to give them additional treatment. I have a patient that I'm taking care of now that he really hasn't needed a blood transfusion. He has a little bit of neutropenia, but not severe neutropenia. Platelets are a little low. Blasts are not increased in his marrow. So if he wants to be cured, which this was what he wanted to be aggressive, so we referred him to transplant to get that ball rolling. Now, if they have increased blasts in the marrow, our transplant centers have different thresholds for tolerating blasts in the marrow because you think of going to transplant with more disease, you don't have as good of outcomes, but it differs from center to center. But there was a recent publication saying if they don't have more than 10% blasts, you could refer to transplant as a first option. And we know that more than 5% is increased. But definitely you think of it as an option more for your higher risk disease. But also, if you have a lower risk patient, is relatively young and doesn't have any more treatment options, this would also be a patient that you could refer to transplant to see if you could cure them and then they wouldn't have to be getting transfused all the time.
There's transplant, there's our common treatments, there's some of the other things that are coming down the pipeline. So thinking about those clinical trials, how do those clinical trials influence your treatment options in people who have MDS?
For sure, it gives us more treatment options, which is always good. But some of our clinical trials, even if there's an FDA-approved therapy for them, a clinical trial might be the best way to treat them. They're watched more carefully and it can help answer a really important question. One of those trials that I was talking about where they're combining epoetin alpha with luspatercept. So I have a patient that's hemoglobin is dropping, but he's not transfusion dependent yet. That would be a person that I would refer to that clinical trial. We would have to make sure that they know that this involves usually more clinic visits, sometimes more bone marrow biopsies, but the patients are really monitored very closely, not just by the person seeing them, but by the clinical trial coordinator and the PI for that study. So it gives us more opportunity for treating them. And, sometimes it's a home run. I can think of some of the individuals I've taken care of that were on the lenalidomide clinical trial, and that got FDA approved for treating patients with 5Q minus MDS and then non-del5Q in combination with erythropoietin. So if there's a clinical trial that they meet the eligibility criteria for and the patient is on board, then we will try to put them on a clinical trial.
More access to care and finding out more answers to cure this for all of the other newer treatment options that you're talking about when we used to just do a few.
I think of the patients who went on imatinib before we knew it was going to be a home run. And I have one patient that I used to work in transplant, but she went on imatinib. CML used to be a deadly disease and she didn't need a transplant, and she's 70 years old now. So clinical trials can really be the answer for that patient. Pretty exciting.
I have just a few more questions for you.
Okay.
How can healthcare professionals evaluate their hidden or implicit bias about MDS treatment?
For MDS, I think what comes to mind is being biased against treating older patients. Like, they've lived their life. Why do we need to figure out what's causing their severe anemia? So just thinking about that, if that patient is still a very functional 80-year-old, we should treat them, not have this bias, like this age bias, which I think is pretty common. But hopefully, if we're aware of it, we won't be biased against treating older people.
Looking at their body age as opposed to their chronological age.
We always start with the age, which I almost wish we didn't say. We say an 86-year-old, and automatically we have this picture in our mind of an old person. What if they're very healthy 86-year-old who doesn't have any limitations? So we always start with the age. It would be interesting to see if we didn't say their age first, if we would make different treatment decisions. And I know we would.
What are some common misconceptions about MDS treatment?
I think that we often think low risk, no treatment needed, which it depends on the person. They often need ongoing supportive care to manage their symptoms, even if they're not getting treatment. And just because we're not treating them, active observation, bringing them in to see how they're doing, to see if they've had infections, if their blood counts are changing, that is paying attention to them and doing something. So just because they're low risk doesn't mean that they don't need anything. And we could just schedule them for a 1-year follow-up. So I think that's one that I see, or that all MDS quickly becomes leukemia. So those are two different sides of this spectrum, because only about 33% of patients progress to AML. So there's a lot of heterogeneity in the diagnosis, and we need to know more details before we jump to some conclusion about MDS.
That's a really good thing to think about. What's something about this topic that's not often discussed but you wish people knew more about?
To know that it's actively being investigated and that we have several treatments that we could really help patients feel better and improve their blood counts instead of just transfusing them. Transfusions decrease survival the more transfusions a patient gets. So send them to a center of excellence and get a second opinion.
It's easy to treat a symptom with something that you can do very easily with those transfusions. So knowing that there's other ways to support them and to hopefully improve their outcomes is really important. What's some additional training or education for oncology nurses to stay current on this topic?
The MDS Foundation has a lot of supportive content for both patients and healthcare providers. I know there's also the Aplastic Anemia and MDS Foundation that has a lot of educational content for both healthcare providers and for patients. And of course, the Oncology Nursing Society is a great place to learn about things that are changing for blood cancers in general.
What are some additional resources for people with MDS and healthcare professionals who want to know more?
Blood Cancers United, the MDS Foundation, Aplastic Anemia and MDS Foundation. HealthTree is a new organization that I've been working with that provides a lot of support to patients and their families, and also caregivers. So caregivers are part of that. There are clinical trials that involve patients and their caregivers. So clinicaltrials.gov may be an avenue for looking for a clinical trial that's based on improving quality of life or learning more about treatments that might be available, that patients could go and look for those. And also for us, if we're trying to help a patient who doesn't have any treatment options at our facility, sometimes I try to help them navigate to a clinical trial that may be open that they can enroll in.
Sara, it's been great talking with you again today. Do you have any final comments for us today?
Continue to pursue knowledge about diseases that you don't know a lot about, because you never know who might be diagnosed with myelodysplastic syndrome. It's a diagnosis usually of aging individuals. And the more you know, the more you can help another person.
Thank you so much. And I hope you have a great rest of your day.
Thank you. I hope you have a great day too.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.